Visible?
Yes, sir.
So, let's see what all the questions. So, first thing is why it's called diabetes? The name. Who is the name diabetes mellitus derived? What languages are involved in this naming?
Greek.
It is a combination of both Latin and Greek. It is derived from Latin and Greek words. Diabetes means siphon or pass. Mellitus means honey like mellitus. Means like so diabetes mellitus. How can you define diabetes? What is the definition of diabetes?
Single fasting blood sugar more than
It's a
126 milligrams.
group of metabolic disorders due to absent or deficient insulin production. That is the definition. It's a group of metabolic disorders due to absent or deficient insulin. And how can you classify diabetes?
Type 1 diabetic mellitus, type 2 diabetic mellitus, and
Gestational diabetes.
Gestational diabetes.
Like others diabetes.
diabetic mellitus,
So
that
four
is diabetes.
okay, classified into type 1 where there is total lack of insulin following destruction of cells of islets of Langerhans, which is by autoantibodies. Second is type 2 due to decreased production and insulin resistance happening is type 2, which is earlier called juvenile diabetes and adult onset diabetes. That is no more the terminology. And third is gestational diabetes occurring in pregnancy. And fourth is due to other causes like drugs, Cushing's disease, etc. Okay, so these are the four types that is being divided. Diabetes divided. What are the complications of diabetes?
Macrovascular complications.
Micro and
Macrovascular complications.
macrovascular occurs in the eye, the kidney, neuropathy. Macro occurs in the risk of stroke and cerebrovascular diseases, including impairment. The heart, it can cause high blood pressure and insulin resistance response to coronary heart disease. And in the extremities, peripheral vascular diseases like occlusion and others. How is glucose balance maintained in the body?
Insulin and glucose. Hepatic glucose production.
Stable internal environment in an organism regulated by insulin, mainly important regulator of this metabolic equilibrium. But other neuronal input metabolic signals are also important. So this is how the normal balance of 4 to 6 millimoles is being done. Is whenever there is an increase in glucose, what happens? It stimulates the pancreas and stimulates the release of insulin. So glucose uptake happens and glucogenesis, neogenesis is reduced. Glycogen is done and blood sugar is brought back to normal. On the contrary, if the blood glucose levels are reduced, then insulin production is reduced, counter-regulatory hormones are stimulated, and all the glycogen stores are released, and blood glucose is brought back. So this is the basic mechanism of balance of blood glucose. Now, what are the mechanisms by which insulin resistance is caused, and what is glucotoxicity? Name the mechanisms causing insulin resistance.
So poor transcellular signaling, the metabolic syndrome, which decrease the insulin sensitivity, the transcellular signaling will be affected.
So abnormal insulin molecule. Patients who develop insulin resistance, Insulin itself is abnormal in structure, and there what are the hormones? Can you name the counter-regulatory hormones?
Yes, sir. Glucagon,
Glucagon.
adrenaline, non-adrenaline.
Pardon?
Glucagon, adrenaline, non-adrenaline.
Norepinephrine. Is the counter-regulatory hormone?
Those, sir.
Yes, sir. Counter-adrenaline one.
Catecholamine. Okay. C squared, G squared. Remember like that. C for
Yes, sir.
catecholamine, C for cortisol. So two C's make C squared. G square is not the real estate agent, but the glucagon and growth hormone. So C squared, G squared, these are the four counter-regulatory: catecholamine, cortisol, glucagon, and growth hormone. But growth hormone takes a long time to act as a counter-regulatory. But these three, glucagon is the most swiftest or fast-acting counter-regulatory hormone. Whenever hypoglycemia happens, this is the one which will be released to improve the blood sugar level. Then comes the next level is the catecholamine and of course cortisol. Then anti-insulin receptor antibodies. They can be direct antibodies against insulin, or it can be the antibodies against the receptor of the insulin in the cell membrane. And last will be the cytokines and target tissue defect. So these four are the causes of insulin resistance. Abnormal insulin molecule. What is the normal structure of insulin?
It's combined of 51 amino acids, sir.
In how many chains?
Alpha and beta.
Two chains. It is not a
chains.
single line or file. Okay, there are alpha chain and the beta chain, which are how are they bridged together?
C-peptide.
C-peptide,
Disulfide bond.
disulfide bond. Very good. So the C-peptide is removed during the formation.
Okay, sir.
We are going to see how the synthesis of insulin is there. Sometimes they ask you about that.
Yes, sir.
Can anyone tell how the insulin is synthesized? What are all the steps in the formation of insulin?
No.
Okay, I'll
This is
tell you.
glucose
Yeah.
and beta cells.
Right. So this is the way the insulin resistance develops. These are the insulin molecules. They come and occupy the receptors here. And once they occupy, it opens the glucose transporter channel. And so only when this occupation occurs, it acts as through the internal cytoplasm, opens what is called the glucose transporter channels, or GLUT, GLUT, GLUT. There are 1, 2, 3, 4, 5, 6. Any numbered glucose transporter channels are there. So these channels open, and then the glucose which is in the bloodstream is taken up into the cells for utilization. Okay? So that is how the insulin acts. And if there is a hyperglycemia, that is glucotoxicity, there is excess of glucose, which normally have to convert by the glucose metabolic pathway up to pyruvate, and this pyruvate will go into the mitochondria, and it will go through the oxidative phosphorylation chain. But when there is an excess of glucose, more than what this mitochondria can handle, this glucose then can get converted into what is called advanced glycation end products, or it can result in production of this oxidative stress, the superoxides, nitric oxide and oxide free radicals, and that is the one which leads to endothelial dysfunction, causing the inflammation in the vessels, and that is why you get the micro and vascular complications. Okay, so this oxidative stress and advanced glycation end products, they damage the endothelium, leading to inflammation, platelet aggregation, leukotriene adhesion, LDL oxidation, atherogenesis. All these changes that happen in the vessels, both small and large size vessels, That is the one which ultimately produces the various organ dysfunction. So the endothelial dysfunction is caused by these three routes. One is advanced glycation end product, second is by the oxidative stress, third is by the reduced bioavailability of nitric oxide. Okay, so these are the three mechanisms by which the entire pathology happens in the diabetic patients. Now a little bit about this advanced glycation end products. They are nothing but harmful molecules formed non-enzymatically by the glucose which is present, which reacts with proteins and lipids. Very simple definition. Advanced glycation end products. They are a harmful molecule, group of harmful molecules formed by the combination of sugar with proteins and lipids, and can be formed both endogenously and exogenously. So this polyol pathway where glucose is converted into other types of sugars, which also go into reactive carbonylase and lipase peroxidation. There is a reaction called Maillard reaction, where this reducing sugar and amino group form what is called the shift base and then amidroid product. All these things ultimately end up in what is called advanced glycation end product. Because alcohol also chronic usage leads to all these things which also can contribute to that. So the diseases associated with advanced glycation end products is not only diabetes but cardiovascular diseases, skin aging, kidney disease and Alzheimer's disease. All these diseases are caused by this particular harmful molecule. And the stages through which it goes are protein plus glucose, they combine to form the glycation. This happens within a few hours and that is called the shift base. So whenever you have constant excess sugar in your body, the first thing that happens is that reduced sugar combines with protein or lipid of the glycation, and then depending upon your body building, then it will go into rearrangement called amidroid product that takes days, and finally it becomes after weeks or months they become irreversibly cross-linked, and so it's a gradual. That is why diabetic it takes number to finally form these complications, and that affects what is called the receptors for advanced glycation end products and activation of nuclear factor B and other pro-inflammatory transcription factors, and the gene expression happening. So pro-inflammatory gene expression happening, which constantly produces this inflammation on the vasculature and endothelium. So the whole process is because of the increase in sugar which is available resulting in this. So that is the reason why we always want to have the sugar under control so that this combination of advanced glycation end products does not happen. And the pathophysiology in type 2 diabetes, there is increased glucose production, impaired insulin secretion, inefficient glucose utilization, increased intake of glucose. Patients also keep on eating glucose, that all lead to the type 2 diabetes. So which are the organs which don't require insulin? Earlier slide I showed you how insulin comes and occupies the receptor on the surface of cell membrane and opens the glucose transporter pathway for the glucose to enter inside the cell. All these cells in our body do not require this insulin to come and get attached. There are some organs where insulin, glucose can still enter the cell's cytoplasm for undergoing the oxidation by the glucose metabolic pathway. And which are all the organs that do not require insulin?
The brain, RBC, the brain, sir. Brain, RBC, the liver.
So that is, can remember this mnemonic, BRICKLE. B for brain, R for RBC, I for intestines, C for cornea, A for kidney, L for liver, D for exercising skeletal muscle. Exercising skeletal muscle, not the resting skeletal muscle, but exercising skeletal muscle. So all these organs, brain, nature has made it like this because brain cannot withstand hypoglycemia for a long time. So waiting for insulin to act and then take up the glucose, most of us will be dead. So that is the reason nature has made it that brain tissue can easily take the glucose directly from the bloodstream. Similarly, RBCs, similarly intestine, cornea, kidney, liver, and exercising skeletal muscles, all these things can take the glucose without the insulin getting attached to the receptor. So how does happen? So the mechanism of increased blood pressure, one is carbohydrate from the intestine. Second is release of hepatic glucose storage. That is, glycogen is broken down and blood glucose level increases. If the muscles do not take up, resting by sedentary life people develop more diabetes. Muscles are not utilizing the glucose, and there is a decreased insulin secretion. All these four factors are the reasons for hyperglycemia. And which glucose transporters are insulin independent? I told you there are up to 6 types of glucose transporters. GLUT, GLUT 1, 2, 3, 4, 5, 6. Which ones are not dependent on insulin to open?
Sir, 1, 3,
5, 7.
5, 7.
2, 1 and 3 are not insulin dependent. Okay, 5 of course sometimes and not all the time. So GLUT1 and GLUT3 are insulin independent. And what are the correlation between capillary blood glucose, plasma glucose, and whole venous blood glucose? It's a very important practical point that we know, we have to know, because nowadays we are checking the CBG, the ICU, in the critical care, in emergency situation as a point of care blood test, bedside testing. So we should know whether the CBG is an accurate to measuring it from the whole blood sample or a plasma sample. So what is the relationship between these three, CBG, plasma glucose, and whole venous blood glucose? Any idea? So CBG is 7% more than plasma glucose. So whenever you take a blood sample and then centrifuge it and remove the plasma, measure the glucose in that plasma, CBG is always 7% more than the plasma glucose. But between plasma glucose and whole venous blood glucose, which is the higher? Just logical thinking. It doesn't have to, you don't have to know medicine of diabetes. The whole venous blood is 15% less than the plasma glucose. So plasma glucose is the one which is accurate, because whole venous blood, part of the glucose will be in the RBC. RBCs also can take up plasma glucose. Other cells also will take up. So plasma glucose will be 15%. Whole blood glucose will be 15% less than the plasma glucose. So the accurate measurement of glucose is done by measuring the plasma glucose after centrifuging the blood sample that you take. But for emergency sake, when you take CBG, you always add 7% to that value. For example, if your CBG value is 100, then the plasma glucose will be 107, not 100 exactly. So it's always slightly higher. So that is how you correlate these three. And the histology of islets of Langerhans cells, there are alpha cells which produce glucagon, and beta cells which produce insulin and amylin, B cells which produce somatostatin, and F cells which produce pancreatic polypeptide. So there are 4 types of cells in the pancreatic islet. And how insulin works, already we have seen. You have the how insulin is released whenever there is a need for when the blood sugar level goes high up. The first step is the glucose enters the cells in the beta cells of the islet of Langerhans, and that is through the GLUT2 receptor, GLUT2 channel. And once it goes into that, it is metabolized and it increases the ATP or converts ATP into ATP by 3, which opens the potassium activated by the ATP channel. So potassium goes out. That is the step number 3. So there is a membrane depolarization. Internal negativity comes down, and that opens the voltage dependent calcium channels. So calcium enters the cell, and then just like your release of acetylcholine at the neuromuscular junction, the vesicles are exocytoses which contain the insulin, and then they are all released through that. So membrane repolarization occurs, then potassium will come back and the whole thing will settle down. So these are all the steps in the method of insulin release. So higher blood sugar level is sensed by this, and immediately insulin is released because of the entry of glucose into that. And here also these two channels are very important. ATP dependent potassium channel to depolarize the membrane and activate the voltage dependent calcium channel. Calcium holds a very important place in the release of insulin. The synthesis of insulin, this is one of the important things. There are various steps. So the first step in the formation is it forms what is called the pre-pro insulin, which has got 3 chains. You have a alpha or A chain, you have a beta chain, you have a C chain with a signal sequence N terminal. Then this pre-pro insulin is broken or cleaved to form what is called the pro-insulin, where the N terminal, sequential terminal is removed. This blue portion is removed, and you have still 3 chains, A, B, and C. And here the C peptide or C chain is removed. After that, it becomes a 2 chain sequence, A and B chain. And this is the sulfide bonds which are attaching between the 2 chains as well as intra chain and the A chain. So there are 3 sulfide bonds, 2 between the A and B chain and 1 in the A chain in between the amino acid sequence itself. So the final insulin is nothing but a combination of 2 chains containing 51 amino acids, 21 and 30 in 2 sequences. And so this is the picture to show. You can see 21 amino acid A chain and 30 amino acid chain. And when you alter the position of this amino acid sequence, then you can produce artificial insulins according to your choice. And that is where the insulin analogs also come here. So the question that I asked you, the Lispro and the one,
Clargin.
Argin is a larger one. So these are the, and this is the another picture to show how the messenger acts. So the insulin gets attached and it gets internalized and it causes the blood to open and glucose entry happening there, and this is how the whole thing happens. The pattern of insulin release is to understand there are two waves of insulin production. Pulsatile release of short-term blood glucose control after you can see this is there will be a basal insulin production spiked by a sudden bolus insulin release whenever there is a increased glucose intake from by a meal. So this is the mechanism how it is acting, and the concept of insulin is to mimic the natural basal and bolus insulin concept. So you can see this red line is a basal insulin. There is a constant level of production. spiced by breakfast, lunch, dinner, and the night insulin. So every time you take, there is an increase. The sudden bolus is there, and the basal insulin is always constantly there. And in the night, whenever there is a stress or whenever you go, there is another added insulin. That is why one of the reasons for that is to produce the early morning hypoglycemia. What is the name for that? What are the two mechanisms where you can have early morning or a fasting hypoglycemia?
Somogi phenomenon and Dawn phenomenon.
Dawn syndrome. Very good. So these are the two things which you have to know. So this is again a picture to show how insulin resistance happens. In a normal insulin metabolism, you will have the insulin attached to the receptor, allowing the normal glucose entry. Whereas abnormal insulin structure, instead of the normal structure, there is insulin resistance, and you find very few molecules entering into the cell. And these are all applications how it's produced. We have seen already. Advanced glycation end products is the name you have to remember how it is causing all the problems. And the other methods are manifest is what is called protein kinase activation, which again leads to the superoxide and oxidase, decrease availability of
You are not audible, sir.
is the screen visible?
Yes, sir.
Yes, sir.
Okay. So the precipitating factors in terms of euglycemic decay, main reason is SGLT2, and the diagnostic criteria for that is moderate hyperglycemia, which is less than 300, metabolic acidosis, and ketonemia. So only difference between the regular decay and this is the low sugar level. So symptoms of this will be again almost similar to that. The only difference that you have to remember between euglycemic and hyperglycemic is when you administer insulin to reduce the glucose level, you will be using it for longer time in decay. Whereas here you have to all the time be watchful about hypoglycemia occurring in these patients. That is the only difference, and you may require to give dextrose containing solutions, which you normally do not use in the regular DKA. So the mechanism how this is caused by the SGLT2 inhibitors are SGLT2. What they do is this drug gets excreted by the kidney in the urine, and it goes and occupies the receptors in the proximal convoluted tubule, which are responsible for reabsorption of glucose, filtered glucose. All of you know that beyond 180 milligrams, which is the threshold, glucose will be filtered in the urine, and it will be reabsorbed by the cells in the proximal convoluted tubule. The SGLT2 inhibitors, what they do is they go and occupy these cells and prevent the absorption of glucose and cause massive glycosuria. They allow all the glucose to be eliminated in the urine. So that is what is glycosuria, natriuresis, and increased ketone bodies reabsorption happen. And that is how the plasma ketone bodies level increase, contrary to the regular DKA, where it is because of the breakdown of lipases and peroxidation of beta oxidation is resulting in ketone productions. So that is this is lipolysis, free fatty acids, and ketogenesis that also is partially responsible, but it is contributed more by the reabsorption of ketones from the uh, urine. And the correlation between HbA1c and the blood sugar is one of the calculations which all of us should know, because when you want to calculate the average estimated blood sugar level, this formula you can use. That is, you multiply the HbA1c by 28.7 and subtract 46.7 from the value that you get. So then you will get the estimated blood glucose level. Of course, majority of the reports now, they give you the average sugar level with the HbA1c correspondingly, but it is better to remember this formula. HbA1c multiplied by 28.7, from the product of this particular multiplication, you subtract 46.57. Then you get the average blood glucose. So you can easily remember the decimal point is 0.7 in both. One is 28, another is 46. So this is how I remember that, and you can also remember to identify that. So what is HbA1c? It is a glycation of proteins in the frequent occurrence in the case of hemoglobin, and it is a non-enzymatic condensation reaction occurring between glucose and end of the beta chain. So that is how the whole beta chain of the hemoglobin at glucose gets attached. And, it is a reflector of control of blood sugar value for the previous 3 months, because the lifespan of RBCs is about 120 days. So you take it as an average for the period of last previous 3 months. And what is hypoglycemia unawareness? The repetitive episode of hypoglycemia, especially at night, can result in this condition in which patient does not respond or appropriate autonomic warning signals will not be there. So neuroglycopenia also has happened in this condition. And how is this condition diagnosed? The blood glucose will be less than 50, indicative of this condition. And symptoms are adrenergic like sweating, tachycardia, palpitation, restlessness, pallor, etc. And fatigue and confusion will be there. And how do you treat that? In conscious patient, you can give oral glucose tubes, tablets, etc. How to treat hypoglycemia is a very important medical emergency. All the doctors and physicians should know. And if patient is unconscious, you can give IV glucose 0.5 gram per kg IV or glucagon 0.5 to 1 milligram IV IM or subcutaneous. And test for parasympathetic dysfunction, of course, all these things we have already discussed. And ECG wise, you can find all these things. And the sliding scale regimen for insulin is another tool. And continuous infusion, you have Alberti regimen, Velour regimen. Velour regimen is very easy to follow because of the simple equipment. You don't require an infusion pump and all those things. Of course, you can read about this. And more important, continuous infusion treatment is important for vascular surgery, cardiac surgery, and pregnancy, and neurological surgery patients. So this is for bypass grafting. Diabetic ulcer foot anesthetic management. Take a detailed history and make sure that the patient's average blood sugar level, how well it was controlled by HbA1c, and whether previous that the patient had any history of angina or coronary intervention has been done. And renally, you must see whether any renal parameters elevated like urea, creatinine, or coagulation, vitreous hemorrhage, and eye complications indicate microvascular problems. And the neuropathy is diagnosed by reduced sensation, altered bowel habit, gastroesophageal reflexes, erectile dysfunction, giddiness when getting up, and effort tolerance is very, very important in these patients. And usually diabetic patients also have thyroid dysfunction, either hypothyroidism or hyperthyroidism. So better to ask for features of thyroid dysfunction also. And examination of the patient, you have to go through all this regular examination. And ulcer, you have to assess the vagus grading and also monofilament test for absence of sensation. So a painful infected wound in the leg can be painful or painless. When it is painless, it indicates that the patient already has developed a diabetic neuropathy. If it is painful, that means he is still having a normal neurological function, peripheral service function is normal. And with regard to the vascular complication, we can measure what is called ankle brachial index. That means you take the blood pressure in the arm as well as in the leg and find out the ratio between the two. It should be normally equal, but when it is when there is a peripheral vascular disease, you will find the brachial pressure will be higher than the ankle pressure. So it will be less than 1 in those cases. And treatment options based on the Wagner's classification. This is the Wagner classification of diabetic foot, various pictures. And investigations, routine CBC, glycemic control, ECG, X-ray, echo, Doppler, wound swab and culture and ultrasound. And optimization before surgery, wound infection control with antibiotic, glycemic control with short-acting insulin, and stabilization of comorbid conditions, ketone estimation, uric acid estimation, etc. And estimation of GFR and assess the grade of renal function and cardiac medication management. And the advantage of regional less stress, less fluctuation of sugar levels, easy to identify hypoglycemia. You can give good intra and post-op analgesic by adding additives, avoiding airway manipulation and aspiration risk. Disadvantage will be hypotension will be severe if there is an autonomic dysfunction, limited duration of anesthesia with a single shot, but epidural is contraindicated because of infection, and hypothermia and shivering is another disadvantage. And GA in these patients, long duration surgery like microsurgery, cover, etc., you require GA. Or if the patient has established autonomic neuropathy, better to go for GA. The patient refusal or severe infection, all these things are contraindications for regional, can be done under GA. Advantages are patients will be comfortable, good operating condition, but if there is a difficulty airway, even patient may appear normal, but like a sedation, I mean, the position in the soft tissues and ligaments that can produce a limited mouth opening, and of course the prayer sign and other things will help you to identify that. And whenever there is a possible RA technique can be combined, like combined spinal epidural, etc., or nerve block or ankle block. If there is a dry gangrene will be good, but in infected cases, don't say about ankle block because it will not work. And IVRA also has been tried in these cases for amputation and other things, provided the area is small where you have to remove the necrotic tissues. And instructions for elective procedure, free of starvation, angiolysis, anti-aspiration prophylaxis, stop antiplatelets, stop AC inhibitors, check CBG before shifting to OT, and instructions to be given regarding anti-diabetic medication. This is a common question they ask about you. So if the patient is well controlled on oral hypoglycemic agent, and if the surgery is in the morning, you can skip the morning dose of the oral hypoglycemic agent. And then if the CBG is less than 100, start a 5% dextrose with normal saline. If the patient CBG is more than 200, only normal saline infusion. Resume oral whenever permitted along with the oral hypoglycemic agent. So these patients will be usually very mild diabetics with a HbA1c around 7 or 7.5 and well controlled OHA, but the surgery in the afternoon or evening. Then allow normal breakfast. Keep metformin and other drug called Voglibos. Give half the dose of glimepiride and restart the drugs after whenever oral is permitted. So drugs to be avoided are metformin, Voglibos, and to this you can also add SGLT2 inhibitors. Glimepiride can be continued at half the dose and not the regular dose. And the third category is patients who are taking OHA plus insulin and surgery in the morning. Omit all the oral drugs. Check fasting blood sugar. 100 to 200 milligram, no insulin need to be given. Less than 100, start 5% dextrose at 50 ml per hour. More than 200, divide the value by 150 and you give the plain insulin intravenously by calculating it by after dividing by 150. And patients who are on OHA and insulin, surgery in the evening, allow normal breakfast. Again, omit all the oral drugs. Half the usual dose of same insulin that patient has been taking regularly. And start NPO, watch out for symptoms of hypoglycemia. Start 5% dextrose whenever the CBG is less than 100. And instructions for all the four groups, resuming oral intake will be allowed early in the post-op, where like a hernia or peripheral surgery, where after 2 or 3 hours you can start oral intake. And blood sugar, how is it managed in cardiac, neuro, or pregnant patients? Is by continuous infusion and strict or drug regime. And this is called the tight control of blood sugar. There are two methods. One is called the fixed glucose regime by Albert E. Thomas, variable insulin by Watts, and of course, Vello regimen is also there. So when there is a need for free flap or anything, then you have to go for blood sugar intermittently you can give, or go for tight control along with general anesthesia, where the duration will be quite prolonged, and both the upper and lower limb being operated, you need to you can't give two different blocks in this case and produce anesthesia for that. So this is what we have to remember in the diabetic cases. So the points that you have to remember is about the pathophysiology in how the diabetes causes all the complications in this patient. And there will be advanced glycation and products. Okay. And with regard to the DKA, you have to go by hourly assessment of all the parameters. The correct thing, first initial will be hydration. Second will be control of blood sugar. Third will be automatically the potassium values will change, and so correction of potassium also has to be taken care of. You don't have to separately treat the acidosis. Once you control the blood sugar and correct the fluid deficit, automatically the acidosis problem will settle down. Okay, so that is how you manage the diabetic ketoacidosis.
Sir,
Ah.
I wanted to ask one thing, that sometimes there is a practice when we are taking up diabetic patient in the morning, when we are having higher blood sugars, like more than 250 around, then we tend to give insulin with NS or DNS. Some consultants prefer that. Is there any thing which we can prefer, or is it better to give subcut insulin only?
Better to give
Subcutaneous insulin, like we are.
subcutaneous. No. Subcutaneous is not at all advised in control of blood sugar.
Mm.
You must always give it only intravenously. Okay, because
Yes.
subcutaneous absorption, especially in patients who are coming for any emergency or in shock, it is very erratic. So it is better not to give subcutaneous insulin. You have to, that's why this calculation is very important. Supposing it is 250, then you
Yes.
divide that 250 by 150. You will get something around 1 point something
1 point something. Yes, sir.
units. So that
Yes.
unit can be given IV. And after 1 hour, you have to check the blood sugar and make sure always err on the hyperglycemic side than on the hypoglycemic side. So do not try to bring it below 100 at any time.
Okay.
Okay? So you immediately convert to 5% dextrose. And you can add 8 units of insulin to 500 ml of biofiltered dextrose and simultaneously give that also. If the blood sugar goes below 100 after giving even this 1.5 units you give, sometimes it may drastically come down because the patient will be already on NPO. So in that situation, it is always safer to keep a infusion of 5% dextrose with 8 units of insulin, plain insulin added to that, and keep it
Okay.
ready so that you can infuse it at the rate of 50 ml per hour, and that will maintain the blood sugar between 120 and 180, which is an acceptable level. And you should always have a CBG machine in the OT and keep checking it every hour so that you don't go below 100.
Okay. Thank you, sir.
Actually, on small request, sir, your slide number 19, 20, 21, when they were going, there was some disturbance in the linkage, sir.
You want to
Can you
show
please,
that again?
yes, sir, 19, 20, 21. That part was explaining the DKA, sir.
This one? Is this the one, Tamashe?
Sir, yes, sir.
So,
At that point of time, your audio was not clear, sir, and video also
okay,
went
okay.
away.
So here, this is nothing but a small description about DKA. What are the causes are infection, missing insulin dose, steroids, and stroke. And it is more common in type 1 people rather than type 2. And type 2 people develop nowadays diabetic ketoacidosis, which is euglycemic because of the SGLT2. And the clinical features are almost like your regular DAK in both vomiting, abdominal pain, excessive diuresis, fruity odor in the breath, and gasping type of breathing. That is the Kussmaul's type of breathing, altered sensorium, weakness due to dehydration. And it is diagnosed by severe hyperglycemia, which is normally more than 300, ketones in the blood, and high anion gap, metabolic acidosis will be there. So these are the three things. So you have to take the electrolyte values also in this. That as well has to be taken. And usually they have initially hyperkalemia will be there. Whenever there is a hyperglycemia, it is associated with hyperkalemia. And when you start treating it with insulin, insulin pushes back the potassium into the cell. And so the patient may suddenly from hyperkalemic state go into hypokalemia. So that is the reason why after 1 hour, first hour is mainly rehydration with normal saline, which may require about 20 to 40 ml per kg during the first hour. And from second hour onward, you start adding insulin. First hour also you can add insulin, calculating it by the blood sugar divided by 150 will be the number of units that you give. Or some people say you can start with 0.1 unit per kg body weight as an IV infusion slowly. Whichever way you want to do, you can do and control. From second hour onward, you start measuring the electrolyte, potassium as well as blood sugar and adjust your insulin dosage. And if necessary, if the potassium goes below 3.5, you have to supplement potassium also under ECG monitoring. And the treatment is by time-bound correction of dehydration with saline during first hour along with insulin to reduce the blood sugar. The correction of hypokalemia from second hour when blood sugar reduces, and differential diagnosis of DKA are these three: hyperosmolar hyperglycemia, myocardial infarction, pancreatitis, starvation ketosis, and alcohol ketoacidosis, ethylene glycol intoxication, lactic acidosis, ethanol, formaldehyde, and rhabdomyolysis, salicylate intoxication, and uremia. Differentiate DKAs from hyperosmolar hyperglycemic state or absence of ketones. That is the most important differentiate. And plasma glucose will be the values. It is be very, very high in hyperglycemic, hyperosmolar state conditions. And pH will be, because acidosis will be there, and the bicarbonate is between it's reduced. Ketones are very limited in this hyperglycemia. That is the most important differentiating diagnosis between DKA and excesses. And osmolality will be very high in hyperosmolar because of the high glucose value. Anion gap is very much reduced, and mental state will be more or less the same. It will either altered sensorium or stupor or coma will be there. And the key features of DKA: blood glucose very high, ketones positive, sodium is low, anion gap is very high, pH is low, carbon dioxide is low because patient will be hyperventilating, potassium will be high, bicarbonate will be low. So this slide will help you to remember all the features of diabetic ketoacidosis. And the triad for these two, again I have seen that shown that in the earlier slide. And pathogenesis of DKA and HSS both are caused by stress, infection, and all insulin insufficiency, and increase in counter-regulatory hormone, absolute increase in deficiency in insulin, which causes lipolysis, free fatty acids, ketogenesis formation, decrease in alkali reserve, ketoacidosis, and hyperlipidemia. All these things happen. When there is a relative insulin deficiency, absent or minimal ketogenesis, that is how the HSS happens. And both will result in increase in the blood sugar level, hyperglycemia. It will cause osmotic diuresis, loss of water and electrolytes, dehydration. The reason for dehydration is hyperglycosuria, causing initially excessive urination or diuresis. And once patient goes into a shock, that time we will start going in for acute kidney injury and the shutdown. And that is how we will go in for decreased urine output. So by the time the patient comes to a hospital, he would have exhausted this osmotic diuretic phase. And usually they land up in a very severe cardiovascular compromised state with a low blood pressure and tachycardia. And, urine output will be more, almost oliguric state, and that is the state they will enter in. So that is the reason why we have to correct the fluid balance in them. First, the hydration is very important. Then you start controlling the blood sugar. So these are all the pictures. Hyperosmolarity happen, and the ketones, absence of ketone is the most important differentiating point. The 5 I's for DKA are insulin deficiency, infection, inflammation, intoxication, and iatrogens like glucocorticoids, thiazides, glutamics, antipsychotics, and other conditions are acute myocardial infarction. CVA also can result in DKA. And of course, glycemic, I think I said about severe hyperglycemia. Patients with normal or within lesser than 250 are called the normoglycemic DKA, and the treatment is similar to hyperglycemic DKA with regard to fluids, but insulin should be titrated carefully to prevent hypoglycemia. That is the most important thing. The precipitating factors for SGLT2, I think from this
This was covered, sir. This slide was covered.
Okay. Okay. So if you are given a case of diabetic foot for management, please remember to know all about diabetes, the pathophysiology, the various systems that can be affected, and important complication is diabetic ketoacidosis. And patients with ketoacidosis should be first treated for the corrected with from the ketoacidosis and stabilized, optimized, and then only taken up for any procedure. Okay, that is a basic thing that we are doing. However much the surgeon may put pressure on you, saying that unless we remove the infection, nothing can be done. Ketoacidosis should be brought down under control. Ketone should come to less than 1 millimole. Of course, urine ketones will reduce, but blood glucose will take some time. But if the best indicator of adequate treatment for decay is patient sensorium. If he becomes normal oriented, that means even if the ketones are slightly positive, you don't have to worry. On the contrary, if the patient is drowsy or not having a normal sensorium, better to wait and correct it and then take up. Otherwise, they will go in for severe CNS depression and the recovery will be delayed. This is the point that they are making. Shall we stop here? Already 8:40.
Yes, sir.
Thank you
Yes,
very
sir.
much, sir.
Thank you,
Yes.
sir.
Good
Thank
night.
you, sir.
Thank you, sir.
Thank you.
Thank you.